you very much. Good morning. Appreciate the summit having me out. I just got off the phone with my wife, and guess what it's doing in Portland? Raining. Yeah, go figure. Who would have thought that? So I'm a pediatric psychologist by training. I work with young people with medical complexity with a specialty in diabetes. And I do both research and clinical care. And over the past 30 years, my focus has been type 1 diabetes and mostly focused on teenagers. The talk today will be a more general talk so that this is applicable to adults, it's applicable to kids, it's applicable to parents, so I want to make sure that keep it as generalizable as possible. It's also just going to be really 5 big and simple ideas that hopefully you can walk away with something of value. I do have to disclose this. Sadly, nothing to disclose. My parents are very disappointed in me that I have nothing to disclose. They're hopeful that I'll be able to disclose something in the future. I do have to disclose this. We just published a book in ADA focusing on working with teens with diabetes. It's a clinician's guide. Parents could purchase this and get just as much out of it as a clinician. I co-authored this with Corey Hood and Joe Weisberg-Benchel, who's at Lurie Children's Hospital. Okay. So, first big idea about the real highs and lows of coping with diabetes. The literature on social support is incredibly vast and very interesting. If you look at all the psychosocial and behavioral literature and all the factors that we have looked at as it relates to any health condition, the most robust factor that relates to both morbidity and mortality in any health condition or non-health condition is social support. So this goes back to some studies that were conducted in Massachusetts called the Framingham Heart Studies. And what they looked at, this was in the 40s, I believe, they looked at a number of different factors around why people get congestive heart failure. And what they found, they added some other variables like some psychosocial variables, and what they found is one of the number one predictors or number one outcomes of both the progression of the disease as well as mortality from the disease is the quality of support that somebody had. Now, they were able to demonstrate that support isn't numbers, support is quality. So from this data, it was established that all you have to have is one good support. You don't have to have a lot. In fact, there's a lot of people who have, are surrounded by a lot of people that are very lonely. And so you have to have one quality support, and you have to be able to mobilize that social support. There were some gender differences. Surprise, surprise. Who do men get their support from? Right. So we get our support from our partners. Women don't need us. They're female friends. So as you can tell, the Framingham Heart Study demonstrated that men who were single were at really high risk for a variety of health conditions, not just getting them, but dying from them. And women, it had nothing to do with whether they were married or not. It had to do with whether they had a social support network, a kinship, whether it was through the church or through their neighborhood or community. It didn't matter, even in their work environment. So there are some negative sides to this. Well, let's talk about one more kind of level of this support. There's a guy named Sheldon Cohn, who's a psychologist at Carnegie Mellon, and he's done some very interesting research on the relationship between social support and getting the common cold. And he did some fascinating work. What he did was he took couples where one of the members of the couple had the flu. And he demonstrated that they had the flu by taking petri dishes and having them run their nose over the petri dish, and then were able to establish, yes, in fact, they had the flu. And the other partner did the same thing, and they had to demonstrate that they didn't have the flu. And so then he took those couples and he had them kiss for some prolonged period of time. Yeah, this is funded by the federal government, by the way. And then he did an interesting thing. He had half the couples stay together in the lab in the same apartment, and he had the other half of the couples separate. Okay? So one of the couples now has the flu, the other one doesn't. They've been exposed through close, intimate contact, and now they've separated half of them, and they've kept half of them together. Who do you think was more likely to get the flu in the non-flu partners? The separated ones. The separated ones. That's fascinating to me, because you would think that closer contact on an ongoing basis increases your risk. But what trumped that was isolation from someone close to you. So that was just groundbreaking research, and it's been demonstrated in other kinds of variants of that study to show how important a connection with somebody meaningful is. So whether it's your child, it's yourself, it doesn't matter. That one of the things you can do is make sure that you have close, good connections and meaningful connections. There is a downside to social support. So there's this thing called the Greivance study, or Greivance story. This will sound familiar to many of you. So what is the Greivance story? So you got a grievance. What's the grievance? Diabetes, right? Why me? Why my kid? And then you personalize the grievance. We hear this a lot, right? This is a personal thing about getting diabetes. It's not a random thing, it's not a genetic thing, it's not an environmental thing, it's a personal thing, okay? So this starts off the grievance story. And then this begins. You tell your story, your grievance story, to anyone that'll listen. And you tell the story again, and you tell the story again. And what happens to your social support network when you tell this grievance story over and over and over again? It goes away. It fatigues your social support network, right? So you know this in your own families, in your own lives. With Caller ID, it's beautiful because I don't have to ever listen to grievance stories anymore. I love my mom dearly, but she's elderly and all her friends are dying and have health problems. She has health problems. And so when I see Caller ID and my mother calling, I'm going to hear a grievance story. And she leads with, you know, Michael, getting old sucks. And then she goes down the road of how challenging it is. And I listen, and I listen, and listen. And it doesn't change, right? It doesn't change a thing. So who do you think are your best friends when it comes to the grievance story? Your best friends are the ones who tell you to stop it and shut up. Those are the people who you really want to surround yourself with, right? Because what we know about the grievance story is the retelling of the story, the retelling of the woes of having diabetes or having a child with diabetes doesn't change anything. And it actually builds up some inertia around isolating yourself from people who could potentially help you. And it's not to suggest that having diabetes or having any other complex or chronic medical condition is a walk in the park. It's just if you want to mobilize social support and you want to keep people close to you, you want people to not become fatigued by your story. And it doesn't mean you can't tell your story and complain. It just means if you're constantly looking for people to validate that position, then you're going to fatigue them and you won't have the benefits of social support, whether you're a kid or you're a parent or you're an adult with diabetes. There's one other aspect of social support that is not helpful. There's this concept we've researched called miscarried helping. So miscarried helping is the dark side of social support. And many of you who if you are parents of a child with diabetes, you'll understand this very quickly. So what is miscarried helping? Miscarried helping is you have a problem, blood sugars. You have a helper, a parent. You have a parent who wants to be a good helper, right? An investment in helping. And you have a parent who is tied helping with the outcome. And what we know about diabetes sometimes is no matter how helpful you are, blood sugars can be very difficult to control. So what happens when a parent engages in helping? Blood sugars don't change, or they get worse. Parents start ramping up more of the helping that they had thought that their child needed. And you see this in if you're partnered up, you see this in your partners. I see it with me and my wife. I just continue to give her more of what she doesn't need because I think that I haven't given her enough of what she doesn't need. And I'm a really great problem solver, and she's tried to explain this to me, I'm kind of dense, that she doesn't need problem solved, she needs someone to listen and support her. But I can't figure that out, and so she talks to me about problems, and I just go straight to problem solving. And when she gets frustrated, then I continue to problem solve with her. Yeah, it's not good. So this is the same dynamic that happens between parents and children, happens between partners, where one partner has diabetes. And so what then starts to happen is now there's conflict emerging around what started out was good intentions to be helpful and supportive. And what happens after that is that people start judging the other person as either not being helpful, meddling, not understanding, or the helpee or the helper starts thinking that the helpee doesn't want help, doesn't care. And so that's when they end up in my office. They end up in my office because they're good families, they're good people, parents want to be helpful, but they don't understand how they got to this point of now they have a lot of conflict around diabetes. So what's the answer to miscarried helping? Miscarried helping simply can be diverted by understanding what somebody needs and listening to that. And oftentimes we're not very good at that because we think we know what other people need, instead of just asking them what could be helpful. And oftentimes just listening is enough. That's a very powerful way to support somebody. It's just listening. Your kids aren't stupid. They get it, right? And they don't need you to problem solve with them. And so really they just need you to understand and be supportive of them. They'll get there on their own terms. They'll figure it out. Same with your partners. That's the dynamic that occurs. Okay. So that's first big idea, social support. Second big idea, behavior's the goal. So in other areas of our lives, we've equated certain things with the outcomes. This is a great example, is exercise, diet equals weight loss. How many people believe that's true? Yeah, in some cases it is, but in some cases it's not. That you can work really hard and exercise a lot and watch what you eat, and you could potentially gain weight or not lose weight. And the Biggest Loser is a good example of this. You see these people working incredibly hard, and they get on the scale, and they've gained 2 pounds. Okay? So it's not as simple as a one-to-one relationship in weight loss as you do these behaviors, you're guaranteed this outcome, right? It doesn't work that way. Now, over the long term, that relationship does exist. It's calories in, calories out. But in the short term, that's not how it works. In fact, in weight management, they tell you the one thing you should never do when you're trying to lose weight is do what? Get on the scale. What a punishing way to try to lose weight, right? So what do you focus on? Well, we'll get to that. Okay. Other thoughts about low-fat diet, exercise means low cholesterol. Everybody believe that relationship exists? No, it doesn't. Cholesterol tends to be heavily genetic. So my cholesterol, I get it tested when I go to ADA and present every year, and it hovers in the 130s. I'm 52, I eat horribly, I drink too much beer, I exercise, but I play hockey, and I undo the exercise by drinking beer before hockey and then after hockey. I mean, why else would you play hockey, right? So I'm blessed with genetics that both my parents have very low cholesterol, and as a result, I have very low cholesterol. So it has nothing to do or little to do with my behavior. My mother-in-law, on the other hand, she's a vegan, so she consumes no animal products. And she exercises regularly, and her cholesterol hovers in the low 200s. So that's the cruel trick of the relationship between, we think the outcome is tied to our behaviors, and it's not always the case. Okay? So how about in diabetes? Yeah, you're already laughing because you know the answer, right? And this is a really hard thing for people to get, and this is the cruel trick of having diabetes from my perspective. I don't have diabetes. I've been doing this for 30 years. I've probably worked with thousands of young people with diabetes, so I feel like I kind of am a member of the club without being one. And I totally get that the relationship between doing what people tell you you need to do, your good doctors and your nurses, and your blood sugars are not connected one-to-one. I've worked with so many people who work incredibly hard at managing their blood sugars, and they're super wacky. And others who do minimally, and they have blood sugars in range a lot, right? So is there a relationship between what you do and your blood sugars in managing your diabetes? Of course there is. I'm not suggesting that there's not. It's not a one-to-one relationship. And so this is one of the challenges of parenting a child with diabetes or having diabetes yourself, is that understanding that there's lots of fluctuation despite how hard you work in managing your diabetes. And so the assumption that if you have an elevated blood sugar or even an elevated A1C, that you've not been doing what you're supposed to be doing, I think starts down a really challenging and difficult road for families with kids with diabetes. So, and I could go on in other health conditions about this relationship because there's very little that's where you connect what you do with the outcome, and somehow the outcome is a reflection of what you do. So one of my good colleagues at Baylor, Barbara Anderson, she's a psychologist, very well known in the field, has made this statement over and over again, that behavior is the most important drug in healthcare and in diabetes. So what do we have control over? We have control over not blood sugars, we don't have control over A1C values, we have control over behavior, right? And so if there's anything that I would encourage you to leave with around this big idea number 2, is we're reinforcing behaviors. We're not reinforcing outcomes, right? So let's go back to weight management. If we're not reinforcing weight loss, what are we reinforcing? Eating right and exercising. That's a win. In diabetes, if we're not reinforcing blood sugars and A1C values, what are we reinforcing? The big 3, right? Insulin administration, blood sugar, checking, carb counting, right? That's what you're reinforcing. That's a win. And what I see when I start shifting this in families is that kids start to feel less responsible for that A1C. They feel less responsible for the blood sugars. And actually, this is something they have control over. And so when they're doing it, more of it, that's good, because when you do more of it, you give more information to your doctors, you have a better chance at actually impacting A1Cs and blood sugars. We go so far as to asking young people to put tape over their meters. We just need blood sugars. That's what your good doctors and nurses need, is the blood sugars. And so parents freak out about this concept, right? But when you have a child who hasn't tested their blood sugar in 3 months, right? I just need blood sugars. I need them to bring them in so that then we can make determinations about insulin adjustment. And so this is a good way to not be reactive and not feel responsible for that number. And frankly, that happens very early on. We see every new type 1 that's diagnosed in our hospital in Portland. And when we come in, it's almost like a game that they're working really hard to have numbers in range. And when that meter starts to move, I started many years ago when it took a long time for the blood sugar comes up. Now it comes up like that. But I would describe it as a roulette wheel. and the ball's bouncing around, and everybody's waiting and hovering to see if the big win happened, right? You know this experience. And how many of us, look at Vegas. We don't win a lot, right? They win a ton. And that's what diabetes is like. And so when that ball bounces out of the winning number, then everybody's head goes down, and everybody looks frustrated. And how does a child interpret that? They feel responsible. It's a loss, right? And so what they do is, what I think is smart, is they stop taking their blood sugars. Because if I don't have to look at the number, then no problem, right? I don't have to disappoint myself, my parents, anyone else. We do, Jill Weisberg-Venchel is actually responsible for this, but one way to avoid this trap is that when anyone takes their blood sugar, whether it's your partner or a child, one of your kids, she tells them to ask that person to say thank you. Because it immediately changes the interaction around the behavior, and it forces you to not respond to the number and to respond to the behavior. So I think that's a really great idea and a simple thing you can do. Okay, so that's big idea number 2. Okay. Big idea number 3. There's this concept called psycholinguistics, which is the psychology of language. If anybody has partners who are lawyers, or you needed a lawyer, or you have family members who are lawyers, you totally get that language is powerful and drives a lot of what we do and think and feel. And so one of the areas that I've found really, really important is how we talk to people about their health and about diabetes. And clearly the words we use shape the way we think, which drives the way we behave. Right? And so I'll give you an example of the language of diabetes where this happens. Bad blood sugars, right? So the language of blood sugars of being good and bad. You may have heard this before, but we say there's no such thing, we tell families there's no such thing as a bad blood sugar. So why would we say that? Because a blood sugar isn't bad, it's information. And we love information. And so by changing the language is every blood sugar is good. We do say this, the only bad blood sugar is the one that wasn't taken. Because if I don't have the information, then it doesn't empower me to make changes. So we don't talk about good and bad. We don't celebrate blood sugars either. You can see this again, is that when blood sugars then come into range, that parents get really excited. And they get smiles on their faces and celebrate. Awesome, this is great, right? And I know that's in good intention, but once again, if you're reinforcing the good blood sugar or the blood sugar in target, then you're not reinforcing the other one, and you're punishing it potentially. About sneaking and cheating. This is fascinating to me, that when you get diabetes, all of a sudden eating becomes sneaking and cheating. Right? How does that happen? It's bizarre to me. I mean, I'll tell a parent, and they'll say, well, he's been sneaking all this stuff. And I said, like, is he eating? So, if they're sneaking, that has implications. If that's the conversation you're having with the person with diabetes, that you're sneaking, and there's an implication of there's this clandestine kind of effort to consume food without the knowledge of somebody else, then it's a cat and mouse game, and you're going to lose, right? They're going to do it better than you'll ever do it, right? They'll figure it out. So they're eating. Now, they may not be eating things you like, and they may be eating too much of things that are not good, but it's not sneaking and cheating. It's eating. And so changing that language is super important. Once again, parents struggle in clinic when I challenge them on their language around this because they see it as wrong. And so that's the words they use. It's a pejorative. It's wrong. So Dr. Harris, you're telling me that it's okay that he eats, a bag of M&Ms and then stores all the bags in his bed. And I said, I don't know if that's okay, but he's not cheating or sneaking. He's just eating M&Ms, and that's not great. And so even just changing small language like that. Doesn't care. The language of different It's not that they don't care, it's really hard. And when kids are not attending to their diabetes, you're going to hate me for this too. I probably won't ever be invited back, but I think that's really good. Because if they're not attending to their diabetes, what are they doing? They're being kids, right? They're being kids. Now there's obviously a balance between being a kid and managing your diabetes, but this drives parents nuts because why are they not attending to this? They don't care. And I said, no. They're 13, they're 14, they're 9, they're 8. They're doing what kids do. And diabetes is not what kids do. That's what adults and doctors do. So this is a good one too. Pokes. You want your poke now? What? Sure. A small change in language, right? But it's important. I hear parents, immediately when I come into the hospital room after a child's been diagnosed, and I say, how are things going? How's it been going? And they'll say, oh, he's doing really well with his pokes. Great. I wouldn't be doing well with my pokes. That does not sound fun. I even go so far as to not use the term diabetic. That's a shortcut for people who have diabetes, and they're part of that club. It's the language that they earned. They have the right to use that language. As a member not in the club, I don't use that language. They feel diabetic when they're with me already. And so I don't need to call them diabetic. I need them to know that I see them as more than just a pancreas that's malfunctioning. That I see this as a person who has diabetes, who's an athlete, who's a student, who's whatever. And so I think it's really important to mind the language around that. Like I said, people say, well, they call each other diabetics. And I said, once again, that's part of being in the club. That's the right. When you have diabetes, you can use that language. That's the shortcut, right? Testing blood sugars. Checking, thank you. Yes. Testing. I passed the test, I didn't pass the test. Control. How's your control? Management, thank you. Very good. You can give this talk, Yeah. These are really subtle but important things. And then I rarely hear this, but I've heard it in the past, is my child's suffering from diabetes, my child's afflicted with diabetes. Those are judgments that I think at some time people feel like they're suffering from it and afflicted with it, but that's not always the case. Most of the people I work with don't feel that way. Like I said, that's in the moment kind of experience. And then compliance. What does compliance bring up when you hear the word compliance? Somebody who's not being non-compliant. Who's non-compliant? Young children, right? They're not listening, they're not being compliant. And so it's a pejorative, but it's a meaningful pejorative in terms of when you're working with young people with diabetes and anyone with diabetes. Okay, good. I like that. Like I said, you should be giving this talk. All right. So, language of diabetes. Once again, the bigger message, take-home message for this number 3 big idea is that be mindful of the language you use in talking to somebody about their health. Talk about, it's a very simple change. When I meet with young people with diabetes, I just simply ask them, how are you doing managing your diabetes? How's it going? What's working? What's not working? It takes the same amount of time as using language that is you're less likely to get meaningful information from. So if you're a parent of a child with diabetes, once again, you want to open the door for the whole gamut of things people do to take care of their health. And frankly, I've never met a young person who is completely non-adherent or non-compliant to diabetes. That just doesn't exist. They may not be doing it optimally, but they're doing something. You know what percentage of people the data shows that are at any given time optimally adherent to diabetes regimen? 7%. 7%. We're asking way, way too much of people to do this, and so it's really important that you appreciate that. Okay. Big idea number 4. So, this is not a new idea. This has been around for a while. This concept of we have 2 brains. It's not right and left. It's emotional and rational. And let me give you an example of how the brain works. I'll give you an example from my own life. I'm a little embarrassed by the story, but I'll tell it anyway. So we needed a new TV. And I'm a smart guy, or moderately smart, and I went to Consumer Reports, looked it up, found the TV I wanted, measured the cabinet. I'm ready for the TV. This is awesome. Consumer Reports, Best Buy, all the right, like 4 or 5 stars, whatever. Okay? Perfect setup, everything, all the right buzzers and bells. So I go to the store, and there's my TV. You know, it's like the heavens part. And I'm like, oh, beautiful. HD TV with cable. And there's 2 TVs right next to it. Yeah, you know the story. Anyway. There's a smaller TV, and it's, well, there's a TV, it's about the same size, maybe a little bit bigger, and it's only about $100 more. And then there's a much bigger TV, and that's about $300 or $400 more, okay? So I have my TV, the smaller one, and then the next size up, but it's got buzzers and bells that you would not believe, and it's only $100 more. And then there's a big TV for like $300 or $400 more. So which TV do I walk out with? The one in the middle, the $100 more TV. And what happens when I get home? Right. So I thought I was a smart, kind of rational thinker. So who bought the TV? My rational brain or my emotional brain? My emotional brain. And the fact is, no matter how smart you are, no matter whether you're an engineer or a chemist or a lawyer or a trash collector or whatever you are, most of our decisions in the world are really driven by our emotional brains. That's how it works. And so this applies directly to caring for our health. So this guy, Jonathan Haidt, he's a psychologist at the University of Virginia. He wrote a book called The Happiness Hypothesis. And in the book, he talks about the emotional brain and the rational brain. And why the elephant is the elephant represents our emotional brain, and the rider on the elephant is our rational brain. So the rider in my brain was at home on Consumer Reports, and then I got up on the rider, or on the elephant, and got to Costco, and then the elephant kind of, after it got a couple samples of food, went over to the TVs and made some decisions, and the rider was pulling the reins back and couldn't, yeah. So riders are analytical, they're information processing, that's how they function. But elephants get things done. They are the emotional driver for us. And so they have to work in concert. Riders will delay gratification, elephants will go for the quick payoff, okay? So how does this relate to diabetes management? It relates a lot, actually. Because think about it. Your kids, or you, if you have diabetes, are constantly engaging the rational brain, the rider of this elephant, all day around food, activity, right? And the rider becomes fatigued because they're constantly trying to analyze and figure out what to do. And eventually the rider becomes so fatigued that the elephant takes over and makes all the decisions. And the elephant's not thinking. The elephant just goes with what they feel, right? So this isn't unique to kids, and it's not unique to adults. It's unique, or it's common for all human beings. This is how we function. So when kids are not doing what we want them to do, we have to consider that their elephants are really making decisions around whether it's eating, or it's around activity, or even taking care of their diabetes. You've got to feed the elephant. You can't ignore it. You can't just be a rational thinker. You have got to feed the elephant. So you've got to give the elephant a little something. You can't, that's why diets like, no. When I see young people come to clinic, it is a punishing experience. They don't come into clinic and doctors say, oh, it's so great to see you, you're doing great. You know what? Your A1C 6%. This is awesome. That's not how it works. They download the meter, they do kind of an analytical thing, they look at the ups and downs, and there's nothing positive about coming to clinic for most people. And so you've got to figure out a way to celebrate the small wins. So how do you do that? Reinforce anything you can. When I have a young person in front of me who's maxing out their A1C at 14% and has been for the last 2 years, what do? What's the small win here? They're in clinic. That means to me they care. They're struggling, but they're there. And so that's what I do, is I thank them for showing up, right? That's a small win. How about punishment? So our prisons are based on punishment. Recidivism rates are around 70 to 80%. Punishment doesn't work. And when you punish someone with diabetes, you're just piling on, because they already feel punished for having diabetes. So one of the ways to success, I say, is no punishment ever around diabetes. Ever, ever, ever. Okay? Remember, there are no natural cues. Why do people not check their blood sugars or take their insulin or count their carbs? There are no natural cues to do it. If you have an infection, there's this wonderful thing called an antibiotic. You take the antibiotic and you feel better. It's awesome. So what happens when you check your blood sugar? Do you feel better? What happens when you take your insulin? Do you feel better? No. There are no natural cues to do this, right? And it makes little to no change. So it's super easy to forget to do it. Once again, it drives parents crazy to think that their child is forgetting to take care of diabetes. But to me, it makes a lot of sense, because it's really easy to forget, because there's nothing going on until you're in DKA or spilling ketones that something's really wrong, and you need to do something. Plan a vacation. Once again, challenging idea is to plan a vacation from your diabetes. Adherence in diabetes waxes and wanes over time, right? No matter whether you're a child, a young adult, an adult, it doesn't matter. And so there'll be periods of time where you don't do as well as you'd like to do. So I say call it a vacation from your diabetes. It doesn't mean stop taking care of your health. It just means backing away a little bit. But planning it means that there's a beginning and an ending. If you don't plan it, it'll go on forever, right? And so I'll talk with young people and say, sounds like you need a vacation from your diabetes. How long do you think you need? How about 2 weeks? How about in 2 weeks we come back to work? Is that okay? They say great. Once again, parents get really nervous about the idea of a vacation for your diabetes, but it doesn't mean stop taking care of your health. It just means stop putting high level of pressure to be optimally adherent and then having an end point to end it. Otherwise, it'll go on forever. Remember that helping is about support and it's not about problem solving. And remember this, that you have to work with somebody where base camp is. So optimally adherent is up here. You need to know where somebody is before we can make small wins. So if the young person I'm working with has maxed out their A1C at 14% for 2 years, their base camp is really, really low on the climb. And so when I set small wins, it's you came to clinic, that's awesome. That's a small win, it gets reinforced. Rather than, you know, we're really unhappy with how things are going because your A1C continues to be really out of whack. That's a mountain and a climb that they can't make. And so understanding where people are at and then small wins from where they're at as opposed to looking too far forward. And the last thing I want to say about this is that I love this quote, is that 80% of success is showing up. And so I think when I have a young person in front of me, when I have a patient in front of me, to me that's success, because that means they need help, they want care, they want things to be better, and so I capitalize on that as opposed to somehow punish them for the challenges that they have in their health. So thank you very much.